Hello. Hello. Okay, good morning, professors, colleges, ladies and gentlemen. Welcome back to the conference. We do hope that you have enjoyed the gala dinner and have a good sleep last night. So this morning, we are going to have the second plenary section, focusing on very interesting topic, such as transdisciplinary collaboration on education and research, lifestyle medicine and long-term effects of child maltreatment. More important, we are honored to have three very famous professors in the field of public health who will accompany with us through the section. Now, may I invite Professor Lê Vũ Anh from Vietnam Public Health Association, Professor Phudit Tezathivadhana from Preventive Medicine Association of Thailand, and Professor Mike Kodun from Queensland University of Technology to get on the stage for starting the section. Thank you. Okay. Thank you very much, dear Professor. Thank you very much for accepting our invitation to be the speakers today. So we do know that you have a lot of difficulty, a lot of works and busy, but you are trying to solve the problems to be here. So once again, thank you very much for the effort and trying to come with it. May I suggest that we have totally 60 minutes for this session. So we have three presentations, and after that we have a whole discussion together. So may I suggest that each presentation should be no longer than 15 minutes. And then we have about 15 minutes left for the whole discussion. Okay. So shall we start with the first presentation by Professor Lê Vũ Anh from the Vietnam Public Health Association. Professor Lê Vũ Anh is a founder and is the first principal of Hanoi University of Public Health. With more than 40 years of experience in the healthcare sector, he had devoted a lot of enthusiasm and focus to the development of the training programs, research and development in the public health sector, development of field training and research foundation, building intervention models, policy advocacy based on scientific evidence. He makes an important contribution for training and capacity building for young staff, generation of trainees, students and researchers, contributing to high quality and important human resources to the public health professional development in Vietnam. He is now the member of the Council editorial board of some international scientific journals in the field of epidemiology and the impacts of the environment, climate change on health. He is the founder and editor-in-chief of Vietnam Public Health Journal. He is also the founder of the Vietnam Public Health Association and play as standing vice president until 2010, and then is elected president from 2011 so far. Now, please welcome Professor Lê Vũ Anh to present a topic on enhancing transdisciplinary collaboration on education and research to tackle priority public health issue in the new era. A view from Vietnam Public Health Association, please.
Thank you so much for being here with me. I address exactly the name of this conference, which is Enhancing Disciplinary Collaboration on Education and Research to tackle the priority of public health issues in the new areas, but with the view from Vietnam Public Health Association. Since we've done the numbers of work during the pandemic, and we learned a lot there, we'd like to share with you a bit of that, and then talk with you some things about what we are doing. I'll be stick here, not going here, since we have only 15 minutes. That's not enough for me to go back and forth. Thank you so much. Now, about priority of public health, I'm sure that after COVID-19 pandemic, we believe with me, we agree with me, that the healthy and safety population must be our highest priorities. Okay? So otherwise we'll be facing with a lot of problem with health from a number of, no, we don't need so much, with health. And why I'd like so much to quote the definition, I think the definition of IOM about public health. He said that public health is a strategic focus for a healthy population. I like that so much, since what we need now is the working, doing, tackling. It's not only talking anymore. And practically, the public health itself reflect in practical by the toolbox called the essential functions of public health. We call that toolbox from now on. Now, what we do, what we did actually, we're not yet finished, so what we do, yes, about the COVID-19 during that time, in order to learn, is that we try to collect a lot of documents coming from different levels, the central level of government, from the Ministry of Health, from the steering committee. That's the first stage of our study. And so the second stage is about document issued by lower level. That means that provincial level, district level, and commune level, to see if the toolbox is actively applied before and after the pandemic. Not before and during the pandemic is better. Now the pandemic is not yet stated as a finish. And the second thing is how to best apply in teaching apply in different level. The toolbox will be applied. The third one, we focus on the function and sub-function be transferred in training and research. Why sub-function? Since we have 9 functions of public health, which, as I said previously, that is very important as a public health, what public health people have to do. And in each function, it covers a number of sub-functions. When you implement all sub-functions, that means the function has been done well. Otherwise, you will be missing. And the last but not least, that we try to update in the real epidemic time, what the tool will be updated and what we improve, what we implement something. Now the second thing that we are focused on is that assessing the importance of grassroots level of healthcare. Grassroots level is very important. We see that if grassroots level is not doing the good work, good job, they would then be, the whole system would be facing with problem. That's the evidence, very, very clear evidence that we saw in during the pandemic. A lot of mortality increasing and mobility increasing and all kinds of things. The system is collapsed. Now, to be certain the important on grassroots level, we have to see 3A, that affordability, the accessibility, availability, all kind of things. Is available at grassroots level? Did health-related stakeholder involved in planning? since we focus on transdisciplinary in this conference, so multidisciplinary will have to be addressed. That means all stakeholders will have to be involved in this, in this time and before that. Is there any problem with the planning for the toolbox? Problem here, I mean that the quality and the capacity of the staff, of the labor working in this field. I mean, the financing, is that enough for us to do some planning for our toolbox? Is that all kind of infrastructures enough for us to do what we've been teaching? That's all kind of thing. Now, what is we find from our result of research? We find that the document issue is a good variable for us to do all kind of study. The second one is the most central level document issue has been repeated at lower level. Is that good to be repeated? Sometimes it's good, but sometimes not, if only repeated. No speciality, local specialty has been involved in order to instruct our healthcare system, instruct our people to do the right thing. Now, there's the silent time. Actually, there's silent time. It lasts about 12 to 12 months before the outbreak has been broken. That's a very, very precious time. In that time, if we did something, we prepare something, we still have a time to save our system. Otherwise, we fail. Actually, the whole system, healthcare, in different countries has been failed in this one. It reflects exactly what we call in our term of epidemiology as the natural histories of diseases. We don't have vaccine. We didn't have vaccine for this time. Just like a measles before. Now, the function two is focused on surveillance system. The focus on prevention and control of diseases has been dominant. Is that good? Sometimes it's good. But don't forget that beyond the epidemic, beyond the COVID-19, we have other things that we have to solve. We have to improve the qualities of work. For example, the elderly people who have a lot of chronic diseases, they need some service daily, but now they could not receive those things. That's a problem. And no document mentions about function, for example, the function 5, function 8, function 9. That's, focused on, for example, function 5 is on law and regulation created during the pandemic. We don't have that. We don't have any document related to that. We don't have any related the function mentioned about the function 8. What does that mean? What does that mean? It's about improving the quality of services during the COVID-19, during 3-year long time of COVID-19. We don't have a mention function 9, which is focused on research during that the pandemic. That's a missing. And more deep research needed for building some model, for building some more activities, more strategy. That's what we found out from our study. And why transdisciplinary important? Now we all see that the multi-sectorial, which has been failed during 40 years of running the Alma Ata program. So now we started, the primary healthcare program with another Astana status quo. Astana status quo. So after 40 years running the program, we feel that transdisciplinary has been failed. We need to strengthen that. Now, multi-factor attack health, cause disease, but medicine is only focused on disease, not health at all. This is a very, very important case. We have to think about that. We are public health people. We are not only dealing with medicine. We have a medicine under the health. Only medicine deal with this pandemic, not health. That's the reason why we have failed at the levels of the whole world. It's not only in Vietnam. Now, multi-risk might cause a health problem, but since we have a numbers of group of risk, for example, climate change is very important. For example, behavior of people is now changed toward making harm to health, and biologies and everything. You know, a numbers of risk factors. Now, solving the problem need collaboration from the state, from experts coming from different disciplinaries. That's a very, very clear. And the outcome of public health, essential public health performance reflects the level of transdisciplinary. We can see that as an indicator for measuring the successful of transdisciplinary or not, after 40 years failing. Now, what should education and research do in helping with this? Human research, I believe that you will agree with me that the human resource is very important for addressing every problem. It's not only health, but other problems also. So it should be a highest priorities. Now, how to best develop human resources at graduate level, that's important. Now, it seems that we forget to do that very, very carefully. We forget to do that. But now we have to read that. So that's why this question is a must to answer questions. Now, could we combine research and training at graduate level? Quite possible. I tried to explore some people. When the first time I came here to meet with people during the dinner time, I asked some very, very young staff, if we can combine research and training at graduate level, is it quite possible? It's very important. Since the way that research approach tackle people is very, very strong. You have to remember that. We have to follow that for a long time. That's good. Now, could we use the toolbox, the essential functions of public health, as an agenda to do a research and do the training at the graduate level? Quite possible to do that. Since the research is focused on that, training is focused on that, monitoring and evaluation focus on that, and then we have something, daily working that we have to remember. Later on, we'll do that by your nature, okay? Now, who should be involved in the full process of training and at graduate level? That will be planned at its level, very, very careful. Take into account that we need 3M. 3M, what does that mean? That manpower, capacity, we mean material, that means management. So all kind of things will be happening at that level. Now, why collaboration important? I suppose that you know that already, but I still wanted you to remember that, since we are focused on that. So long time, Mekong River and its resources has been with us. And we use that, we remember that. So we share time, we share space, we share culture, and we share behaviors. All of that very important things that we share together with the river of Mekong Delta. We share similar stories and beliefs, all kind of things. We share similar flora and fauna, and share common risk also, and life also, and survival also. So that's why we have to collaborate with each other. Now coming here, I heard a noise from someone saying that this will be something like the end, the last kind of conference of our network. I feel sad about that. For the first time, I came here for this conference, even though you have 13, right? 13 meetings already before this one. And you have 15 years going together, quite a long time. But I heard that. I said that, no, we don't like that. We should do something together again. So that's why, I believe that you will never say that, you will never think that the collaboration will be broken. Now, what should the proposal, the last one, but important. what should the proposal for regional collaboration look like? According to myself, my view as a public health network in Vietnam, I view that this should be a long-time collaboration, much longer time collaboration. The field-based training should be focused. It's very important. Field-based training is not training within the wall like this one, with air condition, and know nothing about the field. That's not good at all. So field-based training should be focused. And research applying training should be strategies. Everything will turn out to be a research that make you remember, that make you finding something in reality, and that help you a lot. You have during the time you are training. That's okay, very good.
Professor Lê Vũ Anh, sorry your time's out, so
yeah,
please
1 minute.
finish.
Yeah,
yes.
Thank you. All valuable health-related stakeholders should be involved, not only health. The only health involved will make us 40 years being failed. Only health personnel. Other personnel will be involved in. One health should be the persistent approach. Since we are sitting in one earth, we are sharing the one eco, now one health will be focused. Exchange faculty and students will be planned from now on. Important one. Since locality, speciality will be local speciality will be bring in when you visit each other and you share the experiences. For primary health care, we are not starting from scratch. Even though I said that it is full in transdisciplinary, but we have a lot of experiences. A foundation for this collaboration should be established. That's what we propose. Yeah, thank you so much. I'm sorry.
Thank you very much, Professor Lê Vũ Anh, for giving a very informative presentation. All the questions to Professor Lê Vũ Anh should be remained until the discussion section. Thank you. Ladies and gentlemen, now we are coming with the second presentation by Professor Phudit Tejativahatna. So, Professor Phudit, today is a beautiful Sunday of you. So, very well performance last for everyone. Yeah, okay. So, Professor Phudit Tejativahatna is the director of the Office of Preventive Medicine Association of Thailand, the advisor of the Patnatat Institute Department of Health, Ministry of Public Health, and the director of the Lifestyle Medicine Program for Thai Physicians. Also is a professor of the College of Public Health, Medical and Vet Sciences, James Cook University in Australia. He's a general practitioner by profession and has been a senior executive role in Thailand, public health and private sector. So he have a lot of effort based on the health promotion and lifestyle medicine in Thailand. So now please welcome Professor Phudit with the presentation entitled The Development of Lifestyle Medicine in Thailand, New Multidisciplinary Practice in Managing LCD to Achieve Sustainable Development Goals. Please.
Good morning, everyone. First of all, I'd like to thank Professor Tang and Dean Tur and Wei University and Vietnam Association Preventive Medicine to invite me to join this important conference. And I feel very privileged and honored. So today I will share with you about what is the update in improving quality of health services in prevention of diseases, especially NCDs. I have 15 minutes, right? This is my outline. I will talk about why lifestyle medicine and what is lifestyle medicine and what is going on in Thailand. And I do hope that my presentation will make you a beautiful Sunday once again. Let me start with this. I think many of you know this. This is a report from World Health Organization last year. Use the data in 2019, and you can see 74% of mortality causes of our world go to NCDs. 45 million die every year. And you can see 3 people will die every 2 minutes due to NCD. This is quite important. The more important is that how we gonna overcome this. The WHO and all country members set the voluntary global target, try to reduce the mortality rate, especially for premature mortality rate from NCDs, reduce to 25% by the year 2025. And SDGs, the goal number 3, put the importance of NCDs as the target 3.4. And we have the commitment to reduce at least 1/3 of the current situation of each country of the NCD. And how we gonna achieve this? Very challenging. Let's see, when our world attacked by COVID-19, we found that from the WHO report, we found that most of those who got NCD has more severity and more mortality rate. For example, for diabetes, you can see 3 times more severity. Cardiovascular disease range from 2.3 to 3.9 times. And the bad news is that not just only those who got NCDs already, who hasn't got NCD but has the NCD risk factor, also has more severity and more mortality rate, like those who are obese. I'm not obese yet, but just overweight. Smoking and drink too much alcohol at the harmful level. And Global Wealth Institute show report last year, November, say that the global cause of poor human health and well-being, we have to be responsible for NCDs all over the world 2.3 trillion annually since 2011, and will be at this rate if we don't do anything until 2030. And also the employee disengagement at work, we lost about 7.8 trillion US dollar annually. Okay, this is the world situation. Go to Thailand situation. Same, similar to the world data. We also got the leading cause of mortality. You can see 9 out of 12, the death causes in Thailand go with the NCDs. Number 1 now, ischemic heart diseases, that changed from number 2 10 years ago to ischemic heart disease. And we have mortality rate for NCD about 380,000 per year now. That means we will have Thai people die 44 people every hour. This is very challenging. For the daily data, we share similarity between Thailand, Vietnam, and other countries. You can see the top 5 of cause of death and disability. Vietnam, number 1 is stroke. Thailand, number 1 road injuries, number 2 stroke. You can see number 5 diabetes. Vietnam also number 5. I'm sorry, the arrow doesn't work. Maybe today is Sunday and they stop working. Okay, look at the risk factor. You can see it's come from unhealthy behavior. Number 1 in Thailand, even though we do very good, as yesterday Professor Min appreciated that about tobacco. But sorry to say this, tobacco still number 1 of risk factor in Thailand. And alcohol use, that really is. And you can see this comes from unhealthy behavior about how we eat, how we exercise. Most of us now have very sedentary. And when COVID-19 hit us, you can see we cannot go out for some time. And also our young people, our children, they stay at home, eat junk food, eat easy food, look at the tablet, have this sedentary lifestyle. we need to change this because we know health risk, but the root cause is unhealthy behavior that we want to change. Otherwise, it will go to the final station, which is chronic disease, and will make us a lot of healthcare costs. We found that from this research done by Professor Vichai Ekprakon, he is now professor in Thailand of Mahidol University. He proved that lifestyle intervention can significantly prevent or delay the incidence of diabetes in Thai population. However, the challenge is that our doctors and health team still lack of motivation and how to deal with lifestyle change. We still rely on the expert approach, just order medicine, order investigation, and when people go back to their home, they may take medicine, but they don't know how to solve their problem at the root cause. Let me introduce to you about lifestyle medicine. All over the world, try to fight with NCD for 2 decades. And one of the mechanisms that implemented in our world health system is lifestyle medicine that including with what we call 6 pillars of lifestyle medicine: nutrition, exercise, stress management, substance reduction, sleep healthy, sleep hygiene, and positive connectedness. I mean the social relation. And you can see on your right hand side, those I just presented to you actually on the system, in the system, but it's like separated jigsaw, and we need to hold on together. And lifestyle medicine physician is expected to be the one to coordinate. We are not only the one, but we will coordinate with the other to deliver all of those 6 pillars to the patient to prevent NCDs. This is the concept of lifestyle medicine, focus on prevention, and it is evidence-based medicine. Evidence-based medicine to try to change behavior to become a healthy behavior. And this is rely on multi and interdisciplinary of health professionals. Focus on primary prevention and emphasize the patient-centered and personalized approach because we need to understand individual needs, individual preference, and individual goals, which are different. Okay, let me show you this video for 1.5 minutes so that you understand more about lifestyle medicine. Sorry, could you stop my time so that I can manage the YouTube? I'm very sorry. Maybe the YouTube now stopped working because it's Sunday. Are you okay? Okay. Somebody may change this. Okay. Put the CC. Okay, now it's working. While we are waiting for the YouTube, why don't we sing Beautiful Sunday? Can you stand up, please? So that we have the new lifestyle exercise. Thank you. Sit down, please. It doesn't work. I'm so sorry, but you can watch my video later. Let me skip this. I think now it works now. It's worked now. It's worked now. Okay? I'm so sorry that doesn't work, and I don't want to waste your time. But you can watch my video later. I will leave this. I will leave this with you. Okay, so the key thing is about evidence-based medicine, about getting to underlying root cause of NCDs. All right? Okay, let's go to the situation in Thailand. We try to overcome the problem of NCDs, and this occurred 4 years ago when Dr. Pyro, who is one of our, this man on the top, he went to join the conference for the global health promotion, and he promised with that conference that Thailand will implement lifestyle medicine. So when he came back to country, he talked to Dr. Pontep. He is renowned doctor. He is the former Director General of Department of Health, the man in the middle. And he asked me to help to organize all of the lecturer in Mahidol University in that time and outside university. With the support from Thai Health Promotion Foundation, we developed the training program for physicians in lifestyle medicine. 4 batches were in our project, and 120 physicians were trained. Okay. When we train them, we don't put only theory or knowledge. We also have the practice session and self-study, also the study tour to what happened in the system, like in the private sector at the Bangkok Dusit Medical Services, BDMS, and also at the Bamrungrad Hospital Vital Life Center, and at the Center of Public Sector, the Metropolitan Health and Wellness Institute.
Ajahn put it, we don't have
We
enough.
have three
Yeah,
minutes.
yeah.
So after we train them, we propose to the Medical Council of Thailand, and the MCOT approved the program, and let us have the first residency training in lifestyle medicine this year at Department of Health. Minister of Public Health be the training host, and the Department of Health assigned 4 regional centers to become training center and also develop the lifestyle medicine services. The capacity are 8 cohorts, but this year we'll start with only 2 physicians. But you can see that's really little number. So we developed the short course training to promote those physicians who already have the experience in treating NCDs to enroll in our program, and 300 physicians interested in joining the program. 80 physicians were selected, and we have only 62 physicians passed to the qualified examination at the middle of this month. We still have challenges that we need to overcome. We still lack of awareness and understanding among the general population and our physicians. We need to integrate this into conventional medical practice because most of our doctors still rely on treatment rather than prevention. Time constraint and incentive structure. We now discuss with National Health Security Office to provide the financial support to these new services. And yes, we need more truth of us. We need more professionals to join. So the lifestyle medicine program for non-medical doctor will be developed this year. Sorry, I don't have much time and I don't want to waste your time, but we still have many opportunities to go. We will integrate this into primary health care. The DG of Department of Health talk with the permanent secretary. Will integrate this into primary care setting of Thailand. We need collaboration between public sector, private sector, and also local government, which now the sub-district health promoting hospital transfer to the local government. And yes, we need policy support. And when I go back to Thailand, we will have the national strategy planning for this. And yes, we need to integrate with the new area of digital health, technology and precision medicine, how to take advantage of gene testing and availability of new technology, research and evaluation, and yes, public education and awareness. And we need international collaboration. We know that in Vietnam, you have small group of Vietnamese Society of Lifestyle Medicine, and we would like to learn from you. Yes, let me go to last slide. We believe that in implementing lifestyle medicine, this will be at least one of major mechanisms to help us to overcome the NCDs. And I think that this is the new platform, not just for physicians, it's new platform for public health professionals, that you can show your strength, you can show your expertise in health promotion, deliver prevention to the people. Thank you very much. Oh, sorry, let me just explain this. Thomas Edison says, this slide you can read, the future of the doctor will give no medication. He said this in 1903, now the future come to us. And I do hope that the future of health is lifestyle medicine. Thank you very much.
Thank you very much, Professor Pudit, for a very interesting presentation. For sure, we have a lot of questions for you, but we will keep those questions for the discussion. Okay. Ladies and gentlemen, psychosocial determinants of health plays a very important role in health promotion and prevention. However, not all people are aware of it, especially the long-term effects on health. Professor Michael. Yes, Professor Michael is an epidemiologist who focuses on research and training related to social psychological dimension of health. So he has a lot of experience in working with this field, especially in education and training. Now, please welcome Professor Michael with his presentation entitled The Long-Term Effects of Child Maltreatment on Young, Middle-aged, and Older Adults. Please.
Thank you very much. This topic I'm talking about today is it's an important professional issue, but it's also a very important and sensitive personal issue. And I realise that some of what I say will be relevant to you, will be relevant to your own life experience. And I'm hoping that this presentation will clarify some questions. Yes. Okay. We know that the child maltreatment is certainly in all societies has been found everywhere there has been research. My team has been working in GMS countries as well as in China and other countries in East Asia for around 20 years. And we commenced looking at, in Vietnam, we did some surveys, some early surveys with Professor Nguyen Thanh Huong and Lê Vuong in Hanoi, and then with Professor Chen Quyen Anh and Vo Van Thang and Lu Ngoc Huat. We did a study of university students in 8 universities in Vietnam. Anyway, we asked them to report about their child maltreatment experiences, and we found that they were as common in Vietnam as they are in similar countries. There's been extensive research in China for more than about 20 years with my colleague Chen Jingqi from Beijing, Peking University in Beijing, and we have found that, as expected, that when you ask young people about their experience of sexual abuse or emotional maltreatment, that this correlates strongly with their current mental health problems. And these are studies largely of samples of young people in educational settings. Also, we have found that in various different reviews that the rates of maltreatment are very similar in Thailand and Cambodia and so on. Now, okay. So what are the long-term consequences? Well, for research in Malaysia that we published 2 years ago, we interviewed 2,000 people aged between 60 and 90 in rural Malaysia, in rural Selangor state, and we found that what people over the age of 60 who were interviewed in clinics in these rural areas told us about their childhood correlated with their current risk of violence as an elderly person and their current levels of depression. So they were reflecting on something that happened 50, 60, 70 years before, and that was associated with their current mental health problems. And in Vietnam, we've also, in various different studies, which I don't have time to talk to you about now, we have started to see associations between adverse life experiences and common mental disorders like depression, anxiety, and post-traumatic stress disorder. Now, this is as we would expect, because child maltreatment, we know, is harmful. But what about the research? Well, I can't really cover every aspect of this. But look, research in North America and Europe, there's fairly extensive research with various different populations. But what is lacking is population-based studies, where we can estimate not only the prevalence of violence against children, but also the association with long-term health problems and long-term healthcare utilisation, so the burden of disease. Oops. Oh, here we go. So what we've done... Oh, dear. Sorry. Come on. What we've done in Australia is a study recently published, just to be published concurrently six papers in the Medical Journal of Australia in April this year. And we studied the prevalence, the characteristics of violence against children, the mental health and the burden of disease in a random sample of the Australian adult population aged between 60 and 94. 16, sorry, and 94. Oh, okay, there was 8,500 people in our study. They're all interviewed by mobile phone. I can talk to you about the methodology separately, but it takes a long time. But we are convinced that our sample is relatively representative of the Australian population. We're actually delighted that even now, with all of the privacy barriers, with all of the difficulties of reaching people through your mobile phones, through receiving a text message and then a follow-up message and then a phone call, that some people agree to volunteer. The important thing that we found is that the people who volunteered were very similar to the general population in terms of gender, age, ethnicity, language spoken at home, whether they were Aboriginal or non-Aboriginal. Education level was relatively similar, employment status. So we believe that still it's possible in the 2020s to capture a good sample of the population through mobile technologies. And we published this in several journals, the methodology. So what did we learn from our interviews with 8,500 people? And well, okay, I'll talk to you about the method. Sorry about the technology here. So I know that many of you are not familiar with research into violence against children. So I just want to say that there are 5 major types that capture most of the violence that happens against children. There's physical abuse. We're not talking about mild corporal punishment, smacking someone for doing something naughty. No. We're talking about repeated, severe physical punishment that is intended to harm the child and that often does leave cause physical damage to the child. This is repeated pattern of behaviour which is on a relatively severe level. With emotional abuse also, we are talking about emotional maltreatment. This is where parents will often threaten the life of the child, will often threaten to abandon the child, will tell the child that they are worthless and that they wish they had never been born or they wish they were dead. This is severe emotional maltreatment, not mild criticism. So we also asked about exposure to domestic violence, witnessing violence in the home. And we all of us know about exposure to domestic violence is one of the most common forms of violence against children. And it's basically, while the violent acts themselves may not be directed to the child witnesses them. And this is the variety of exposures that we talked about. And then, of course, we have sexual abuse and neglect. The sexual abuse we asked about is about unwanted and contact and non-contact sexual events, primarily contact sexual events, penetrative, attempted penetration, or actual vaginal, oral or anal penetration by an adult or a peer. So this is on the severe end of the child maltreatment experiences. Now, and we asked about a lot of health characteristics. We used a validated, internationally validated scale called the MINI, which captures reliable and valid estimates of common psychiatric disorders, depression, major depression disorder, anxiety disorders, post-traumatic stress disorders, cannabis dependence, alcohol dependence, the more common disorders in society. So this is what we, now the key findings, and yes, we're going well for time. The key findings is that the prevalence, now this is the prevalence across the entire sample adjusted for the age strata. Remember, they're aged between 16 years old and 94, but we had 3,500 young people aged 16 to 24, because we're mainly interested in them. We also had 1,000 people in each age cohort, from 25 to 34, 34 to 44, 35 to 44, upwards 65 plus 1,000 people. And we find that the most common exposure is exposure to domestic violence. 4 in every 10 people said that this had happened to them. 3 in every 10 had emotional abuse, 28.5% sexual abuse, and so on. These estimates from the Australian population are relatively similar to other European or English-speaking countries. And now, importantly, anyone who studies this field realises soon, that quickly, that these types of abuse rarely occur in isolation. So that there's a lot of overlap. It is actually a very common experience that 2 in every 5 people, around 40% of people, had more than one type of maltreatment, more than one type. 62% of people overall, 2/3 of people said that they had at least one type of maltreatment. In fact, but the figure of around 1/3 of people who tend to skip through their childhood. And it doesn't matter where I look at this. You can look in China, you can look in Indonesia, or in Vietnam, or in Australia, or in other countries. You generally find about 1/3 of all people say that their childhood had no problems, right? Well, lucky. They're very lucky kids, right? But so now the more severe end is where we have 1 in 4 people say that they had 3, 4, or 5 types of violent exposure. Come on. Okay. Right. Now, the links between child maltreatment and mental health. This is the mental health in the past year for most of the measures, or some of them a lifetime. And what we found that this figure here, this 20%, is of people who reported no maltreatment experiences, and they said that at some time in their life, particularly lifetime depression, that had an episode. Now that figure of about 1 in 5 is consistent with what you find in many countries. But for those who reported maltreatment experiences, it was nearly half. Nearly 1 in every 2 of the adults who were exposed to child maltreatment had some mental disorder. And you can see the different types of mental disorder. There's a clear difference between those who did or who did not have child maltreatment. Now, importantly, we also looked at health risk behaviours, and so what you find is that the level of smoking amongst adults in the Australian population is double that. This is the odds ratios. It's around twice the level of persistent smoking late into adult years is more likely amongst people who with a history of child maltreatment. But the biggest effects was a 6 times higher rate of cannabis dependence, and then also self-harm and suicidal acts in the past year were significantly more common amongst people who were abused as a child. Now, unfortunately, for many people, time does not heal these wounds. For many people, time does not heal these wounds. The impact of maltreatment on mental health appears to be similar across the lifespan. Okay, thank you. So what we're able to do is compare the different age cohorts. And you can see very clearly here that the relative rate, the comparison between maltreated and non-maltreated, okay, the comparison between them in the youngest, middle and the oldest groups was much the same. That the magnitude of the difference is consistent. There's no evidence here amongst these males in our sample that that excess risk is different. It doesn't seem amongst the oldest people that the correlation with child maltreatment is any less. The time does not heal the wound. And for females, you see the same, almost the same pattern, that the excess risk amongst, for all of these conditions, these 4 conditions, or any type of psychiatric, psychological disorder, is the same, regardless of age. Now, and finally, we also asked about the burden of disease, the impact that this may have on current, or this is past year, healthcare utilisation. So we asked people about their visits to hospital, to general practitioner, to psychologists, to nurses and others. What we found, in our population generally, in Australia, around 12%, 12.7% in this sample, had been to hospital, had been admitted to hospital within the past year, right? About 1 in every 8 people had been in hospital in the past year. Now, what we found is amongst those who reported a history of sexual abuse, it was 1 in 5. It was 19%. Those with a history of physical abuse, it was nearly the same. We also asked about reasons for presentation in hospital, and the primary reason was depression, but there was also suicide risk and drug dependence disorders. Now, people went to hospital for many other reasons, of course, primarily for chronic physical diseases and for accidents. But amongst them all, the most common were those 3. Now, my last slide is this one, I think. Yeah, so when we have a look at, this is the people who have multiple child maltreatment experiences, and you can see that for those with 1, compared to people with no child maltreatment, the 37%, those with 1 had a 22% higher risk as an adult decades later. 4, 5, 6 decades later, they had a 22% increased risk of going to hospital that year. If they'd had 2 types of child maltreatment, it was 43% higher, and 3 or more types, it was 58% higher. That is a linear dose-response relationship with something that happened when they were children. In terms of visits to general practitioner, these are people, we looked at the people who go to the general practitioner most often. So people who go at least once per month to see a healthcare provider, largely a GP. For people who are frequent visitors to GPs, they were twice as likely to have had a history of child maltreatment. And then we looked at, there were some people in the sample who had visited a GP 24 or more times per year. These are very frequent healthcare seekers. And that group, that small group, nevertheless that group was 3 times more likely, 3.3 was the odds ratio, 3 times more likely to have a history of child maltreatment. So in conclusion, the prevalence data that we have in this study, which has only just recently been published and was funded by the National Health and Medical Research Council, is consistent. The prevalence, thank you. And we have that exposure to domestic violence in particular is the most common, and I will just conclude by saying that time does not heal the wounds, all wounds, and prevention is essential. And not only for the promotion of well-being in the population, but for the reduction in the healthcare needs for the future generations. So I want to thank you very much and say that for all of you here, many of you have had these experiences, and myself included, and now I'm 65 years old, I can remember very clearly my own childhood, and I can remember the adversities, and I also remember that being able to overcome some of that. And I'll just conclude by saying that for those of you who've had these types of experiences as a child, that one protective factor and where you can not be so impaired, or how you can not be so impaired, is to have at least one person in your life who can provide sustained love and commitment and optimism for you. And in my case, it was my mother. And so I like to dedicate all of this work we have done to the memory of her. Thank you very much.
Thank you very much, Professor Michael Dunn, for sharing with us a very interesting topic. So, once again, thank you very much, all three professors. You are trying their best to present the very interesting and informative topic within a very short time. So, we put a lot of pressure on you while presenting, and you're looking for the time warnings as well. Everything, yeah, as well. Okay, thank you. So we have a very few minutes additional times for discussion. Only, maybe, may I ask organizer to give us about 5 minutes more? Okay, thank you. Oh, 10, yes. Thank you very much, 10. So, we have time. So, now, start with the discussion. So, may I ask if any participant have questions for our speakers? Okay, microphone, please. Yes. Okay. One lady first.
I'm Sri Moman. Thank you, Professor Michael. My question is for you. You mentioned that time will not heal the wound. Yeah. But I think what we can do with the time can heal the wound. I would like to know if there are any prevention measure to kind of like to take out the burden of maltreatment. Like you said, like childhood maltreatment can have kind of like adverse effect on adult life. So I think, yeah, time will not heal it, but what we do with the time can at least reduce that adverse effect on the adult life. So yeah, kind of like a specific example, how can we take care of those who already maltreated during childhood?
Thank you. That's a very important question. I think that the system-wide approach is to have what we call trauma-informed care. And so, as we can see, that for someone who is a very frequent, who has very frequent healthcare needs, that the majority of them, the great majority of that group in our society had severe child maltreatment. Now, mostly in conventional healthcare with GPs, it's not mentioned. It's not acknowledged. It's not understood. And I think that with trauma-informed care, it can be important and can be beneficial if someone who is coming with chronic disease and very frequent attender is asked about their childhood, and when necessary, where there's clear signs of trauma, that they can be referred to for psychological care. There's no simple solution. It depends, and it varies a lot by the type of maltreatment, and particularly the worst of kinds, the most injurious kinds is child sexual abuse, and there are complex mental health needs for many people who've had that experience, and they're not always successful, but often people can be helped, and so the burden can be reduced, even when it's acknowledged late in life.
Thank you, Professor. Professor, yes? Professor Lạc Ngọc Quang from Hanoi Public Health University, please.
Good morning, lady, Professor. Thank you very much for three presentation. It's very, very important and very interested in for us. And I just have some question. Maybe the first question for Professor Michael Dunn. Because actually, for the lifetime, we face quite a number of abuse, not only child abuse. We also teenager abuse. We also have adulthood abuse. So I do think that here your presentation about the child abuse. But what do you think about the teenager or maybe adulthood abuse for the we could at least for the mental problems?
Yes, okay.
Yeah, thank
No,
you.
thank you for that question. Yeah, look, it's a very important one, and the evidence shows that peer abuse, teenager on teenager. Now, in our study, we asked about child sexual abuse, but that was abuse not only by caregivers and adults, but also by other peers. But in general, the research shows that peer-on-peer maltreatment is as injurious, is as severe in its impact as abuse from a parent. Emotional maltreatment, perhaps, is more severe when it's happening to young children than peer-on-peer abuse for 5-year-old, 6-year-old, 7-year-old children is usually not that severe. But when that's perpetrated by a parent, so context is everything. But I'm glad you raised the question about peer bullying and peer-on-peer violence. There was also an aspect of our study, but there wasn't time to talk about that today.
Okay, thank you. So I think we should have, okay, please.
Good morning, the panelists and the audience. I'm Ajahn Pung from Laos. I'm interested in the lifestyle medicine that Professor Pu did just presented recently. We don't have such a curriculum or course like that in Laos, and I'm interested in what are the core courses of that lifestyle medicine college, and from your perspective, how the lifestyle medicine contribute to multisectoral collaboration for health. Thank you.
Thank you for the question. For the main curriculum, they have, I mean, all of lifestyle medicine physicians have to understand about the 6 pillars of lifestyle medicine as I shown. They need to understand how to prescribe nutrition for patients. I mean, for those who are healthy as well, who come to receive services from them, and also for those who got NCDs, like if they got diabetes mellitus, what kind of nutrition should be prescribed? And yes, the lifestyle medicine physician cannot work by themselves. They need to work with dietitian, for example. And secondly, for 6 pillars, it's about nutrition, how to prescribe nutrition, how to prescribe exercise, what type of exercise, the intensity of the exercise, something like that. Thirdly, how to help patients for stress management, stress reduction, like assist them, coaching them how to do meditation, how to practice mindfulness, for example, or yoga. Fourthly, it's about sleep hygiene, because they need to understand how to advise patients how to get well sleep, and smoking cessation and alcohol reductions, and also have the positive psychology. And the main tools for lifestyle medicine is about how to change behavior through the behavioral change theory. 2 major things we teach them is about transtheoretical model or state of changes. They need to assess the state of change of people, because sometimes when patients come to see us, we just order, while we don't see if they are already to get that treatment or not. And secondly, it's about motivation interview and cognitive behavioral therapy, so that we can convince them and help motivate them. That's the main curriculum. And the other will be about the update in lifestyle medicine, like precision medicine and genomic medicine, something like that, digital health. Yeah, that's good. First question. And secondly, about the multi-sectoral collaboration, right? As you can see, there are many services that integrated into lifestyle medicine. We cannot do by ourselves. We need the dietitian, we need the sports science, we need the health coach, we need the other health professionals come to work together as the health team. And that's why we think that lifestyle medicine can help the people-centered or patient-centered care and also multi-health professional care. Thank you.
Thank you, Professor Fudit. So we have one question left. So anyone? Okay, okay. Okay.
Yeah, I keep micro. Sorry. Thank you for your 3 presentation. I'm very excited to see all of your presentation, and I have 2 questions. One question for Dr. Lê Vũ Anh and another question for Dr. Phuket. The first question for Dr. Lê Vũ Anh, I just want to know about the Vietnamese Public Health Association, because you mentioned about the lack of quality service and research in the systems, in the grassroots system. So I'm not sure that currently Vietnam have any initiatives to improve the quality of service and research in the community health worker and grassroots system or not. And the second question, I would like to ask Dr. Phuket about the lifestyle medicine. I understand about a little bit about lifestyle medicine, but I'm not sure how now in Thailand the operation of the lifestyle medicine in the system. It's like one patient. I'm not sure the way that the patient or the healthy people come into the service. It could be have a referral system, or it either one center and then they come in and then they are diagnosed and then refer the service. Can you explain more about that? Thank you.
Yeah. Respond to your questions. I would say is that the biggest questions that we learn from COVID-19 is that the grassroots level healthcare system is very weak. It's very weak now, and we need to strengthen that, develop that and strengthen that. That's very, very important. How to do that? We need health staff, right? Capacity, ability. They will be doing the work that they need to do. And that, it seems that that's the focus on essential functions of public health. They don't have to do that at the university or whatever level. Now, after doing that, can they do that? Can they able to do that in the field? That's a question. Now, for doing that, for fulfill the work very well, they need, one is that the human resources for health. So they need to do. And my suggestion is that, now the best of doing thing is to start doing some sort of studying. So they will have to do some study on that, based on the guidance of faculty member, of the staff member surrounding them, of everything. We have to plan for that. That's what I propose for after COVID. That's what I propose. And they need also the material to do that. For example, laboratory. If they need laboratory, they will have to do that. If they need something like field work, they need to have some fund for that. That's all kind of things that we have to do. And now the good news is that after receiving the bad news from COVID-19, the government of Vietnam is now having some plan of strengthening the grassroots level, and they don't know how to do that. And what we propose that people working in public health will have to do. University will have to do that. Again, they have to teach the lesson of how graduate from their university or be doing something like doing very well the functions of public health function, for example. You don't have to do that. And they will be under the supervisions of all CDC, provincial level CDC, or other stakeholder at the provincial level. So all sort of stakeholder will be involved in training, and the training will be best if it will apply the approach of research. That's what I propose. Yeah, is that your question? Yeah, thank you.
Thank you for the question. For the model of lifestyle medicine services in Thailand, actually established in private sector by the Bangkok Dusit Medical Services, or in short we call Bangkok Hospital Network. And they spent about 10 years. Firstly, no specialists want to get involved, but after 10 years now, specialists want to do more of prevention. And they refer patients from specialists to lifestyle, because we don't have lifestyle medicine physician before, okay? They refer to the wellness center, that what they call, but actually they deliver about lifestyle medicine services, and we learn from them and try to use their lesson to be translated into public sector. And now the Department of Health get the initiative by assigning 5 centers, including in Bangkok, and 4 centers in the region, to develop lifestyle medicine services, and also the training center. And we are at the early stage of development, and we would, the DG of Department of Health, try to communicate with the network of health services belong to the Ministry of Public Health, try to do the referral and sell the idea. And I think it's still early for me to tell you that what will be effective or not. But if you would like to know next year, please invite me to join again. Thank you.
Okay, thank you very much for your questions and for very informative answers from Professor. Okay, we don't have time, so thank you very much, Professor, for your effort and expertise to share with us today. So we don't have time. So Dr. Tu, do we have a certificate of appreciation for the speaker? Okay. So once again, thank you very much, Professor. Thank you.